Eversana and iRhythm have worked on a real-world evidence study on healthcare resources utilization and costs associated with arrhythmias in patients with type 2 diabetes. This retrospective claims-based analysis evaluates the demographic, clinical, and economic disparities among patients with type 2 diabetes, specifically those diagnosed with cardiac arrhythmias. Utilizing data from large U.S. healthcare databases, the study examines healthcare resource utilization, medical costs, and the effectiveness of early detection strategies, including ambulatory electrocardiographic monitoring. Findings reveal substantial differences in comorbidity burden, socioeconomic factors, and healthcare expenditures, underscoring the need for targeted interventions and optimized preventive strategies. Cardiac arrhythmias are frequently encountered yet underdiagnosed complications in patients with type 2 diabetes, exacerbating disease management complexity and increasing the risk of adverse cardiovascular events, including stroke, heart failure, and sudden cardiac death. Evidence suggests that undiagnosed arrhythmias, particularly atrial fibrillation, are associated with a significant rise in morbidity and mortality. This study aims to quantify the impact of arrhythmias on health outcomes and economic burden among type 2 diabetes patients by comparing those. This retrospective analysis utilized claims data from the Meritive MarketScan and Symphony Integrated Dataverse databases, covering the period from January 2006 to July 2023. Cohort definition. A dataset comprising 32.1 million type 2 diabetes patients was analyzed. After applying exclusion criteria, the final cohort included 16.8 million individuals categorized as follows. Target group: type 2 diabetes patients with arrhythmias, 1.19 million, 7%. Comparator group: type 2 diabetes patients without arrhythmias, 12.3 million, 74%. Excluded group: type 2 diabetes patients with specific arrhythmia exclusions, 3.25 million, 19%. To enhance comparability, an index date imputation technique was employed to synchronize event timelines between groups. Patients were matched one-to-one based on demographics, comorbidities, and disease severity indices. Healthcare resource utilization and costs were analyzed for the 12 months preceding and following the index date. Subgroup analyses were performed to evaluate the impact of ambulatory EKG monitoring on clinical and economic outcomes. The arrhythmia cohort exhibited significant demographic and clinical differences compared to controls' age and gender. Older age distribution, 35% age 76 to 80, and a higher proportion of males, 57%. Comorbidity burden, higher ECI scores, with 23% reporting severe comorbidities, ECI greater than 15 versus 2% in the control group. Hospitalization and emergency department visits. Arrhythmia patients had significantly higher rates of emergency department visits and hospitalizations before and after diagnosis. Annual healthcare costs were substantially elevated in the arrhythmia cohort, primarily driven by acute care services surrounding the index date. Financial strain was more prevalent in arrhythmia patients, affecting 50 to 59% compared to 41% in controls. Food insecurity was reported by 72 to 79% across all groups, highlighting economic vulnerability. There was also a higher prevalence of housing and transportation instability and access challenges noted in the arrhythmia cohort. HbA1c data were available for only 8% of arrhythmia patients. Among these, 56% had controlled diabetes with HbA1c levels less than 7%, while 13% had poor glycemic control with HbA1c levels greater than 9%. Patients with arrhythmias demonstrated an increased need for advanced therapeutic regimens, with significant escalation from metformin monotherapy to insulin-based therapies and sodium glucose cotransporter, 2 inhibitors such as empagliflozin. Patients undergoing ambulatory EKG monitoring experienced fewer hospitalizations and improved clinical outcomes. They also saw a reduced incidence of major cardiovascular events and lower acute care expenditures. The findings of this study underscore the substantial clinical and economic burden associated with cardiac arrhythmias in patients with type 2 diabetes. The disproportionate prevalence of severe comorbidities and increased healthcare utilization in this population necessitates targeted management strategies, including optimized Medicare coverage and interventions addressing social determinants of health disparities. Arrhythmias, particularly atrial fibrillation, remain undiagnosed in approximately 11% of cases, with silent atrial fibrillation prevalence estimated at 23% over 2 years. This undiagnosed cohort often presents with adverse cardiovascular events, such as stroke and heart failure, prior to arrhythmia diagnosis. Ambulatory monitoring technologies offer a promising avenue for early detection and risk stratification, reducing both clinical complications and healthcare expenditures. The economic viability of widespread monitoring remains a critical question, warranting further cost-effectiveness analyses. The high prevalence of food insecurity, financial strain, and housing instability among type 2 diabetes patients with arrhythmias suggests that social interventions may play a crucial role in mitigating disease progression and improving outcomes. Policy efforts aimed at expanding access to affordable monitoring and preventive strategies should be prioritized to curb the clinical and economic burden of undiagnosed arrhythmias. This study provides a comprehensive evaluation of the interplay between diabetes and arrhythmias, highlighting significant disparities in health outcomes and economic impact. Findings emphasize the necessity of enhanced care coordination, targeted financial and nutritional assistance programs, and improved glycemic monitoring for high-risk patients. Future research should explore longitudinal outcomes to refine intervention strategies and assess the cost-effectiveness of routine arrhythmia screening in patients with type 2 diabetes.